Yeah, so it's just a kind of basic overview of urodynamics. I sent out what the objectives were before, just kind of understanding reasons for it, reasons not to do it, or who not to do it in. A little bit about the setup, which honestly in the United States is usually done by a nurse, and a lot of times the physicians aren't too involved in the setup, but you are kind of ultimately responsible for the results, and therefore I think the setup and understanding how to do it can make a big difference in troubleshooting issues. And then I think the most important part for us today is going through what you get, what kind of results you get, and what you can use that information for. So urodynamics, generally using it to assess the lower urinary tract function and dysfunction abnormalities. Obviously, the lower urinary tract, the bladder, is for storage and emptying of urine. And really, I think the idea of urodynamics, especially in my practice, is trying to reproduce what the patient is telling you is bothering them, so that you can see if there's something pathologic going on and give them an idea for treatment. So we're trying to identify lower urinary tract dysfunction, and then how that dysfunction could possibly affect the upper tracts, which is obviously very important in terms of renal function long term. It can be helpful when we want to predict for a patient what a treatment is going to do for them, whether it be medical management or surgical. In certain interventions, things like Botox, certain different neurologic conditions, we might want to assess if our treatment made any difference. And then obviously when something just isn't going right, maybe you either tried a medication or tried a surgical intervention and you're not getting the results you expect, or the patient isn't getting the results that they expect. You can use urodynamics to assess that as well. I think I'm in a general practice, in private practice, I think, not at a university, but overall, whether university or private practice, I think the potential diagnoses of the big things we use this for are stress incontinence, overactive bladder symptoms, whether it's just urgency and frequency, or even nocturia, but in addition, leakage, secondary urgent incontinence. I think the most common thing that I see is mixed incontinence, right? A little bit from each column. Important things, especially in the world of urology, for the amount of men that we see and treat, would be bladder outlet obstruction. And then I think something really important whenever we're talking about urodynamics and things to take away from it would be, dangerous situations like detrusor sphincter dysynergia in our neurologic patients. And diagnosing that can really make a difference in someone's long-term overall medical outcome. Kind of generalization of what you're looking for. So obviously, like everything, you always start with an H&P. A neurologic exam if you have any thoughts about neurologic condition. Obviously, a GU exam if you're worried about, some sort of obstruction either from the prostate or some abnormality in female anatomy, like a prolapse. Obviously, a lot of people use a symptom score that's easy to assess, take from the patient. Everybody loves avoiding diarrhea, although patients hate to do them. I think the bigger, so this is all obviously before the patient even gets there for their urodynamic testing, but in terms of the actual prep for the invasive portion of the procedure, urinalysis looking for infection. Now, prophylactic antibiotics are a little bit controversial in the world of urology for everything. We used to give everybody an antibiotic for any procedure, but is it really necessary? Probably not. In patients with a known neurologic condition and neurogenic bladder who maybe are on a cath regimen or an indwelling catheter, probably should get 1 dose of a prophylactic antibiotic. Questionable if someone has a large post-void residual and you're worried that they're going to be in retention after you've just introduced a catheter to them, that could be a reason. Bacteria that you picked up on your prep urinalysis, but without symptoms, and then obviously sick patients that are immunosuppressed. So many a times, almost comes out to everybody's getting a prophylactic antibiotic. We use one in my practice on all patients after they have actually a urinalysis a couple days before. In terms of what to consent the patient for and make sure they realize, obviously you want to talk to them about what you're trying to find out with the test. But risks with the test are relatively low. There is a risk of giving them a urinary tract infection, and that's why you're checking a urinalysis and possibly giving them a prophylactic antibiotic ahead of time. Small chance of blood in the urine, although the catheters are very small. And then right after the catheters come out, most people have, maybe one episode of dysuria from the catheter having just been in there. I think another important thing, though, is sometimes we can't reproduce the symptoms. And that can be obviously frustrating to patients, right? Because we don't have any answers for them. So when not to do it, I think importantly, if someone has an active urinary tract infection, so bacteria in the urine with symptoms or a positive culture with symptoms, obviously we would reschedule ours. And then of the important things to really think about would be someone with a spinal cord injury and autonomic dysreflexia, with a high spinal cord injury above the thoracic, T6, is you can send them into an episode of hypertension and bradycardia with the filling of their bladder. And so if you really need to be doing urodynamics because of their neurologic condition and they have a risk based on their spinal cord injury level for autonomic dysreflexia, I think you have to have a plan to be able to empty their bladder very quickly if they start having any symptoms, as well as having a plan for an immediate release antihypertensive available, either like difedipine under the tongue or something like that. In terms of anticholinergics, so I think that comes down to your practice and what you're looking for. So if a patient has been on multiple anticholinergics or been on an anticholinergic that was working and no longer is working, you might actually want to do the test on the anticholinergic. Most commonly, I have patients stop their oxybutynin or something like that 48 hours ahead of time. But there are cases where I actually have them still take it, especially in neurologic patients or neurogenic patients who have been on that medication for a long time and now their symptoms have changed or worsened. You want to see is their bladder findings or their detrusor pressures worsening on those anticholinergics. So you may want to keep them on that. So that's a relative contraindication. So there are two main parts of urodynamics, right? There's the non-invasive uroflow, which you might already have access to on your own in your own practice, since there's not as much equipment necessary for that. And then the invasive portion, including cystometry and a pressure flow study, as well as looking at the sphincter with an EMG. And I'll go through each of these throughout this. In terms of the uroflow, I think the important thing whenever you read about it is trying to recreate the person's normal circumstance. So privacy is the big thing. So usually you have a separate room, and if you have a system set up, you don't need a nurse or yourself in there. Usually you can get the printout in another room or after the person has gone, has voided, to try to recreate their normal circumstance. So standing in men or sitting in women or older men who might need to sit is going to probably give you the best results. The hardest part I find in my practice is people do not, for some reason, want to arrive with a full bladder. No matter how many times you tell them, they will urinate before they come to the office. And it's, so, a lot of times you'll get a uroflow result and the voided volume is 25 cc's and the residual is 0, and it's not very helpful. So really, I think the standard is 150 cc's or more in your bladder on your final uroflow test is going to be helpful. And really low voided volumes are not as helpful. So good luck trying to get them to come with a full bladder though. What you're measuring on your uroflow, right, is obviously how fast they go, right? How many milliliters per second on their max flow, how long it took them to go. Again, the voided volume, so you know if you had a good test or not, along with the post-void residual. Obviously, if your voided volume is 20 cc's and their post-void is 500, it's still a good test. If your voided volume is 25 cc's and their residual is 5, not all that helpful. And then usually you'll get a printout of your flow curve. So here showing a normal, nice parabolic curve. This is kind of a stuttering or staccato curve. You can see very flat curves as well, usually in prostatic obstruction. So in terms of the invasive portion, so starting with the cystometrogram, and just trying to show a picture, you have your fluid you're going to instill through a urethral catheter into the bladder, a small balloon in the rectum, and then a patch near the, in women, near the urethra, or in men, usually near the buttocks for the sphincter. So, and each one is going to give you obviously a tracing, as well as measuring how much volume you put in. So the urinary catheter is measuring the pressure within the bladder. The rectal balloon is measuring your abdominal pressure, and when you subtract those two, we're supposed to, that will give us the pressure of the actual detrusor muscle. Our EMG is going to give us a tracing of what's going on with the external urinary sphincter, and then we obviously are measuring how much we put in. I didn't add on here. There's also a uroflow portion that's going to measure how much came out. So just the same picture again, kind of showing, right, the urinary catheter, rectal balloon, and then the patch electrodes. So I have just a bunch, as we go through this, different tracings kind of going over it. So kind of a general tracing showing you, your catheter in your urethra is measuring your vesicle pressure or your bladder pressure. Rectal balloon is measuring your abdominal pressure. And when you subtract those two, you should get your muscle, the actual detrusor muscle itself. EMG electrodes here. And then this here is showing the urination or a leakage in terms of the outflow. And then this is showing the volume instilled into the patient. So this is a pretty standard setup that you'll see. So in terms of the International Continence Society, there's some very specific things that you want to look for and start with. And so I'm going to start with the patient sensations, which I have, and then we'll go through other things you're going to look for on this EMG, both detrusor overactivity, leakage, and I think very important, compliance, especially when we talk about patients with neurologic conditions. So this very busy slide. This is very similar to what my studies look like in my office. Oops, sorry. Let's see if I can go back. So when you start off, you have your catheter in the bladder, you have your rectal balloon, and they're both going to be having some sort of pressure to them. You want to make sure that they're both working and that you're getting a signal from them. So we ask the patient to cough at the very beginning, and this is the spike that you get right here. And that's just making sure that you're getting a tracing and that each of the transducers in the rectum and the one in the bladder are picking up the signal. The important thing to realize, which I think sometimes gets lost, especially maybe with a nurse who was learning how to do urodynamics for you, is these numbers in the bladder and in the rectum are not going to be zero. And so they should, if they're both at zero all the way down here, then you have something wrong, okay? Because the pressure within the rectum and the bladder at rest is not zero. When you're talking about a patient, most commonly the test is going to be done with the person sitting down. Even with men, we usually do the test sitting down, although sometimes we will stand them up. And so at rest in the sitting position, the pressure within both the rectum and within the bladder should be somewhere about between 15 and 40 centimeters of water. So when you subtract those from, and they're going to be about equal, when you subtract them from each other, then your resting beginning pressure of the detrusor muscle can be anywhere between -5 and 5 overall. So sometimes people freak out when they first get the test, and this green line here, which is really the one we want to be looking at, the detrusor pressure, is maybe below, here you can see it's at -5 because here's -10. But that's normal, right? Again, it's just a math, it's just the subtraction of the abdominal from the vesicle. So that cough at the beginning is a good way to make sure that you're getting a good signal and that your numbers are starting off at the right place. So then as you start to fill, you always want to ask the patient beforehand and give them the instructions ahead of time. You're going to ask them for when they first feel like they're the first sensation of being filled, when they start to have a desire that they want to use the restroom, but they could delay it. And then the big one is the strong desire. And so, usually we tell people, when would you, get up from a conversation and go use the restroom? When would you excuse yourself or get up from your desk? I had a professor in training who always said, when would you leave your grocery cart at the store and go find the restroom? So strong desire. And then once you've stopped the test and you're going to give the person a chance to go to the restroom, you can mark their capacity. So after you've marked off, you know, all the patient's sensations, the things important things we look for on the tracing are going to be detrusor overactivity. So an involuntary contraction of the detrusor muscle, of the bladder muscle, while the bladder is being filled. And this can sometimes have no symptoms whatsoever, but can also give the patient symptoms of urgency. They can leak during it, given obviously urgent continence. Can be related to a neurologic problem, but not obviously. There are many people walking around who have no neurologic disease whatsoever and have detrusor overactivity. And you know, in one study looking at, you know, about 15% of people who had, you know, healthy volunteers for a urodynamic test have detrusor overactivity. So you can find it quite often. The issue is many a times you'll have a patient with urgency, frequency, symptoms, and you can't reproduce the detrusor overactivity that you expect to see on the urodynamic. So a couple tracings about showing some detrusor overactivity. So again, up here is our rectal catheter, so our abdominal pressure, our urethral catheter, so our bladder pressure, and then subtracting them and we get our bladder muscle, our detrusor pressure. And so our green line is pretty flat. And then we have, you know, no provocation, and we have a detrusor contraction without an abdominal contraction going on. So we know that, you know, they're not bearing down. And obviously on this, they marked it in the detrusor, they had an overactive or uninhibited contraction at 50 with pressure of 54 centimeters of water. And then it does come back down in this one. I have a couple others. This one, you know, not as pronounced again, but the green line showing again the detrusor pressure with a, you know, being filled, an uninhibited contraction. It can be provoked as well. So you can have an abdominal contraction as well at the same time. And then this is what you see a lot of times on a test, especially in someone with a neurologic condition, is throughout their entire filling. So here's the blue line of them being filled through the whole test. And here is your, in this, the colors are flipped. So the green is actually your abdominal pressure. The purple is the urethral catheter, and the detrusor pressure here is in red on this one. And so you're having uninhibited contractions that come back down, another uninhibited contraction that ceases. And so you have this kind of rhythmic uninhibited contractions throughout filling. And this is pretty common what you'll see in someone with multiple sclerosis, Parkinson's disease. It's pretty common. So, you know, detrusor overactivity, you can have leakage with that as well. There can be leakage obviously related to stress incontinence. And you can have a combination of a uninhibited contraction or a stress maneuver leading to an uninhibited contraction or stress-induced urge incontinence. In terms of leakage, the big things are going to be the two different leak point pressures that are important. So there's leak point pressure related to a detrusor contraction. And so that's the detrusor leak point pressure. And this is the lowest pressure within your detrusor from the detrusor muscle when leakage occurs, either with absence of an abdominal contraction or an increased abdominal pressure, or absence of the detrusor contraction. It's one or the other. You don't have to have them both. And I'll show some examples in a second. But decreased bladder compliance or a poorly compliant bladder can lead to leakage with the leak point pressure, that increased resistance of the outlet, either through detrusor sphincter dysinertia or from obstruction with an enlarged prostate. And I'll talk about this a little bit more when we get to compliance, but the big number that I think everybody in the world of urology knows for years and years from Dr. McGuire, you know, over 30 years ago, is a detrusor leak point pressure of 40 centimeters or more is concerning for risk to the upper tract. So this is picture or schematogram is showing a lot of different things going on it, but the point being just a drawing of the leak point pressure. So here we have no abdominal contraction, and then a contraction within, or leakage, and it's the lowest pressure when leakage occurs. So we're showing leakage down here, and you'll measure the pressure within the detrusor, which is going to be a subtraction again of the abdominal from the vesical catheters to get your leak point pressure. And this is obviously a real study, so with a lot of arrows on it, and I apologize, but this is kind of how I look at my test, is I'll look across it all together, and you look down at the bottom, and usually your nurses also flag this for you, is, and get my cursor to work, there's a leakage that's pointed out here, there's a leakage that's pointed out here, and if you go up from there, you see that there is a lack of abdominal contraction. There's a lack of abdominal contraction here because this red line is relatively the same all the way across. You have a contraction within the urethral catheter, and that's going to lead to a detrusor contraction in the absence of an abdominal contraction with a leak. And so that detrusor pressure right there is going to be your detrusor leak point pressure. So in this case, you know, they're right next to each other. So it's either going to be 70 or 66. In this one, it's 49 or 50, depending on exactly which number you're going to pick. And usually I will document in my study, you know, that they had a detrusor leak point pressure of 66 at 212 cc's. And then just kind of two more examples, the same idea. So we have, here we go, no contraction. So you can either, it's a leakage at the lowest pressure, that you have leakage at the lowest pressure with no detrusor contraction in this situation. And in this situation, it's no abdominal contraction. And obviously they measured a leakage there. So in this situation, we're talking about poor compliance of the bladder. In this situation, you can see the EMG is firing. And so we have likely some detrusor sphincter dysinertia. But you can have absence of a detrusor contraction and still leak, and that is still considered the leak point pressure. Or you can have absence of an abdominal contraction with a detrusor contraction and have a leakage, and that's still the leak point pressure. I think that's sometimes where people get hung up. Again, this is that first example or earlier example I showed of detrusor overactivity. So each one of these episodes is a detrusor overactivity. Up here in this study is where they're showing the leakage, and so I try to circle them here. So you would measure your detrusor pressure, which is in red here, at this moment, and that would be your detrusor leak point pressure on both of these. Valsalva leak point pressure is what we use obviously for stress incontinence, and so it's going to be a measurement from the urethral catheter, which is the pressure within the bladder, so the vesical pressure. When leakage occurs either from an abdominal contraction or increased abdominal pressure and the absence of a contraction of the detrusor muscle. So it is a measurement to some degree of strength of the sphincter to keep a person from leaking. The lower pressure needed to push urine past that sphincter, the weaker the sphincter is, right? So if it takes a lot of pressure to leak past the sphincter, you have a very strong sphincter. And that comes into play when you're starting to talk about stress incontinence in women and things like intrinsic sphincter deficiency versus, you know, urethral hypomobility, which I'll talk about a little bit in a second. So the Valsalva leak point pressure, some people also call it the abdominal leak point pressure. It's the same thing, obviously. So a low leak point pressure, less than 60, intrinsic sphincter deficiency. What we're most commonly seeing, you know, with urethral hypomobility in women with stress incontinence, considering a surgery such as a mid-urethral sling, is usually a much higher leak point pressure, greater than 90. So how I do my challenge for leak point pressure for Valsalva leak point pressure for stress incontinence is usually you wait until the person has at least 150 cc's in them. Ask them to, and I do both a cough, and I'll show you on a couple slides, it's kind of hard to see on the cough, and then you ask them to do a Valsalva, usually over about 3 seconds, and that you can usually see the actual pressure that you're trying to read better on the Valsalva. We then usually repeat it in my practice at 250 cc's, and then usually at capacity as well. A lot of times, though, even though the urethral catheters are really thin, some people just won't leak, but you know that, you know, they should, or that you could reproduce it in the office. without a catheter in. So you can remove the urethral catheter and you can use the abdominal pressure as your leak point pressure if necessary. So again, just a schematogram showing an abdominal contraction, no detrusor contraction, and leakage. And so you're going to measure your valsalva leak point pressure from the urethral catheter. And this is the same thing. So no detrusor contraction. We have an abdominal increased pressure, and we're going to measure what the valsalva leak point pressure is from the vesicle pressure or the urethral catheter, which in this case is 109 centimeters of water. So a high leak point pressure. And this trying to show, this is usually the cough here, and this is the valsalva. So you can see that it's a much wider, and you can probably see the number on this. You can't see it because it's a little blurry, but you'll be able to read the number much better. So if they leak with a cough, but you can't catch it, you can always ask them to valsalva over about 3 seconds, and you'll be able to catch it a little bit better. And again, on all of these here, there's no detrusor contraction, but there is an increased abdominal pressure, and then you'll measure your valsalva leak point pressure up here from the urethral catheter measurement. Obviously, finding overactive bladder, urgent incontinence, stress incontinence is important, but I think, one of the big things with urodynamics is really trying to figure out who's at risk for upper tract disease. In our patients who either have spinal cord injuries, multiple sclerosis, Parkinson's disease, other neurologic conditions, transverse myelitis, is important because we want to, manage their kidneys appropriately, prevent renal failure, which is obviously a big cause of death. So, and that comes down to bladder compliance, right? So how well does the bladder distend and hold urine at a low pressure? So the whole point of the bladder, right, is to store urine at a low pressure and then obviously void urine. So we're looking at the change in volume within the bladder as it relates to the change in pressure. So you need 2 points. So you're going to look at the pressure from the detrusor at the start, which is usually close to 0, somewhere between -5 and 5. And then the detrusor, usually at capacity or just before any overactivity episodes. And it can range quite widely. And there's really no normal for compliance, although the big thing is to look for low compliance. So a compliance less than 20 is considered concerning. So I will tell you, most people don't sit and calculate this out. So, but it is good to kind of be able to look at it and know what you're going to find. So here, and this one, the detrusor's in green here, and you can see it's rising throughout the whole test, rising along with the urethral catheter as you would expect, and the abdominal catheter is pretty flat. And then here is our volumes at the bottom. So at 150 cc's instilled, our pressure here is 50 centimeters of water, and our compliance is 3, which is obviously very poor. And you can just look at this and tell that it's very poor. You have a flat abdominal tracing, and you have a very steady rise in your detrusor tracing. Same thing here. They keep switching the colors. And so we start, the detrusor pressure here is going to start at 0 way down here on the left-hand side. And you can just see, without even having to do a calculation, that it's rising the whole time. And our abdominal pressure is staying flat. And obviously that corresponds with the vesical pressure going up. The detrusor pressure is going up. Down here we have 423 cc's instilled. We get to a change of going from 0 to 61, and then our compliance is 7. You can, if you're doing a urodynamics and you're actually there for the test, and you don't expect the person to have a poor compliance, especially in someone who does not have a neurologic condition, but you see that the detrusor pressure is quickly going up, you might just be filling too fast. So most times, you're filling somewhere between 10 and 20 milliliters per minute. If you're really up at 50 milliliters per minute for your inflow, you're probably going too fast. Obviously, in someone with a neurologic condition, you kind of are expecting this, both spinal cord injuries, myelomeningocele with spina bifida, and detrusor sphincter dyssynergia. very bad bladder outlet obstruction, men with bad BPH who've, you know, been urinating against an obstructing prostate for many years may have poor compliance. And then obviously any problems with the bladder contractility itself, right? So radiation, cystitis, and tuberculosis. I think what the majority of people look at really though is the storage pressure. And this is kind of getting back to Dr. McGuire's work, is really, you know, is the detrusor pressure greater than 40 centimeters of water? And that's putting the upper tracts at risk. So I don't think, in my practice, I do comment on the compliance and I comment if it looks normal versus abnormal, but I don't actually calculate out the actual compliance number. But I will comment on if the detrusor pressure is sustained above 40 centimeters of water. So in this study here, we're going to look at the red line, which is the detrusor pressure. Again, our abdominal pressure is relatively flat, and you can see starting at 0 how it is just slowly increasing, and they've marked it here, you know, 32 centimeters of water, 42 centimeters of water, 45, 50, and then 44 here. So, you know, I would mark in my dictation that this person has a, you know, persistently elevated detrusor pressure above 40 centimeters of water, and that's going to put their upper tracts at risk. But you don't actually have to sit there and calculate out, you know, 200 milliliters in, 50 centimeters of water and change, you know, a compliance of 4, because I don't think anyone actually uses that number. It's really, I think, the detrusor pressure consistently above 40 centimeters of water, putting the upper tracts at risk. I know I talked very fast. Any questions in general just about the CMG portion and either compliance or uninhibited contractions with detrusor overactivity or looking for stress incontinence?
No. We don't have questions.
Okay. So then the second portion of the test, right? So the first portion is the filling, and then the second portion is the voiding phase, right? So pressure flow studies, similar to our Uroflow, but we're going to get more information because we have the catheters inside. So we'll get a flow rate again, like we did on the Uroflow, but now we're going to have how much pressure is the bladder muscle generating to push that urine out. So our detrusor pressure at our max flow, how much obviously the person urinated, and then usually checking a post-void residual either by a scan or by a catheter at the end. And so you're trying to obviously assess the relationship between the bladder muscle, the detrusor muscle, and the outlet or the sphincter or the prostate with respect to BPH. So in a normal functioning lower urinary tract, you should have a good high flow of urine, and the bladder should not have to work very hard to push it out. So a low detrusor pressure with a high flow. Bladder outlet obstruction, BPH, even detrusor sphincter dyssynergia, you're going to have an increase of the detrusor contracting, and it's going to be pushing the urine out very slowly. What I don't go into a lot today, talking about underactivity of the detrusor, so atonic bladder, right? You're going to have poor flow and a poor contractility of the bladder as well. But I think the big thing that most people are looking for on urodynamics is trying to determine, is there bladder outlet obstruction, and is this man going to benefit from a TURP, right? I mean, the mainstay of urology is the TURP, and so we want to know in a gentleman who maybe has had these symptoms a long time, is this going to help him? Does he have bladder outlet obstruction, or does he have something else like significant detrusor overactivity and poor compliance, but no outflow obstruction? Again, a thing that I don't think a lot of people sit around and calculate themselves, but a lot of systems, if you have a Labrie urodynamic system that will calculate this for you, is what is the bladder outlet obstruction index? And I have a picture of it in a second. I do not sit and calculate this, I'll tell you. So you're going to take your detrusor pressure at your max flow, so the detrusor pressure at the Q max, and minus twice the Q max. So a higher number is going to be obstructed, the lower number is not obstructed. And this is really specifically for men and looking at BPH and outlet obstruction. Women is a little bit different. You know, I think you can look at this in a woman who's already had maybe a sling done previously and now is having new symptoms afterwards, such as urgency, urgent continence, and is their sling obstructing them? So if you think of it in a woman with no prostate, obviously, they should be able to have a very high flow of their urine when they void. So a low Qmax under 12 is usually a sign of obstruction in a woman, or a very high detrusor pressure at their best flow. So a detrusor pressure of 25 or more at their max flow, it can be a sign of obstruction in a woman. So this is looking at bladder outlet obstruction index in men, right? So in this case, you have your detrusor pressure pretty flat the whole time. This is the patient voiding, right, which we can tell because they got to capacity. They were probably then given a instruction that they could void. They're not using their abdominal muscles to void here because their rectal catheter is pretty low. And then they're measuring here the peak moment when the urine is coming out here. And so our detrusor pressure is 54. So the computer usually will calculate this for you, or you can do it yourself. Their max flow is 17 milliliters a second. Their detrusor pressure at that Qmax was 54. So the bladder outlet index is 20 and they're not obstructed. More commonly, what you'll see on a lot of systems is it'll calculate it for you down here, right? So in this case, we have a detrusor pressure. The max flow here is 9 milliliters per second. That pressure at that max flow is 74. And in this case, they are obstructed. So 74 minus 18, and we get 56. And it draws it for you that they're obstructed. That's a much easier way to do it. And then kind of the final part in terms of the urodynamics, both during the filling phase and the voiding phase, would be the EMG. And I think the EMG can be the most frustrating part for urodynamics because it's not a great study, right? You're using patch electrodes near somebody's, perineum to tell us what their external urinary sphincter is doing. And there can be a lot of artifact, but it can be helpful, especially in patients that you are concerned about having detrusor sphincter dyssynergia. So I thought that this is a nice drawing kind of showing what the sphincter is supposed to be doing throughout filling and voiding, right? So our sphincter is firing while we're all, not voiding. And then as we get more full, we're going to have a guarding reflex. So actually, as we get more full, the sphincter, there should be an increase in the EMG. When you ask someone to cough or Valsalva, you'll also see an increase in the EMG, right? Because they're guarding against leaking and they don't want to leak. When they do urinate, obviously the external urinary sphincter should relax. And then after they're done urinating, you'll see the EMG again. It never, ever looks this clear. It usually looks like a lot of noise.
Excuse me. Can you, what is the definition of EMG?
Oh, the electromyogram for so the neurologic signal from the external urinary sphincter.
Okay. As I told you earlier, it's a little bit new for us.
Oh yeah, so, no worries.
Ask you a lot of questions. Yeah.
Oh no, I appreciate that because obviously in medicine we all use a lot of shorthand that we don't always remember that is not standard across everybody.
Okay.
Obviously, go ahead.
Can you go back to the last slide? Can you repeat like the explanation? I didn't really catch it.
Sure, of course. So this is honestly the best way I think of this is, so the EMG is what is our sphincter doing, right? Our external urinary sphincter, what is it doing throughout the test? And so if we think about sitting here right now, all of us, our sphincter is closed and it is actively closed, which I'll go through in the next slide briefly, actively closed while our bladder is filling. And so when your bladder is pretty empty and there's not a lot of pressure as your bladder fills, your sphincter is working, but it doesn't have to work too much. As your bladder gets more and more full, so here's the bladder volume going up. As your bladder gets more and more full and you're getting more and more uncomfortable, your sphincter is working harder and there's a guarding reflex so you don't leak. And this is the increased activity of it. When you then urinate, your sphincter opens, and it is being inhibited, and it opens. And where my cursor go? And so there should be no activity of the EMG of the sphincter. And then after you finish voiding, it'll start working again, right? Because it's closed off to allow you to start filling. So in terms of the bane of all urologists' existence of how we actually empty our bladder, and both the sympathetic, the parasympathetic, as well as more voluntary control. Very busy slide, but I think the big things are what we're measuring with the EMG is right here, the external urinary sphincter, okay, which is under somatic control from the pudendal nerve. And it is when we are sitting and filling, that is active. And so as the bladder fills, that's where this EMG noise or that you're going to see, and I'll show it in another picture in a second. At the same time, as the bladder is filling, the hypogastric nerve or the sympathetics are being stimulated to allow the bladder to relax and hold urine. As we get the bladder more and more full, there's going to be a signal of pressure within the bladder. That does increase the signal at the pudendal nerve, and that's where you get this reflex or guarding reflex, okay? And then the active voiding is going to be an inhibition of the pudendal nerve, allowing that to open, and that's going to decrease that signal that we just saw. And then you're going to get your parasympathetics are going to turn on and cause a contraction of the detrusor muscle. And I think this and the previous slide, which I'll show, is going to come into play when we start talking about neurologic conditions. So let me see in this next one. So really, the EMG is helpful for me when you're worried about a neurologic condition such as detrusor sphincter dyssynergia, right? And that is going to can put the upper tracts at risk. So detrusor sphincter dyssynergia, so a discoordination or impaired coordination between the bladder muscle, the detrusor, and the sphincter when you're voiding. Because again, voiding is a contraction of the detrusor and a relaxation of the sphincter so that you can void under low pressure, right? There's no, the detrusor does not have to contract too hard to push the urine past the sphincter. But in neurologic conditions, spinal cord injury, multiple sclerosis, transverse myelitis, pretty much any lesion between the pontine micturition center, so midbrain and the sacral spinal cord, if you have lesions in that area, it's going to cause a disruption to inhibiting the guarding reflex. Again, the guarding reflex is as you get more full, your sphincter is going to be stronger to keep you from leaking. But when you go to start to urinate, that guarding reflex is supposed to be inhibited, right? We're going to turn off that guarding reflex so the sphincter can open when the bladder contracts. And so the way to think about it, detrusor sphincter dyssynergia is the sphincter is still contracting when the bladder is contracting, and they're working against each other. Mm-hmm. And that's going to lead to increased pressure and risk to the upper tracts. DSD or detrusor sphincter dyssynergia is a neurologic diagnosis. So the person has to have a neurologic condition. Again, multiple sclerosis, spinal cord injury, or something like that. If a patient does not have that condition, we then call it dysfunctional voiding or pelvic floor hyperactivity, where someone is not relaxing their pelvic floor. So I think this is this is a good tracing of a sphincter or an EMG, right? So here is our urine filling up the bladder, our volume going in. We have our detrusor pressure here, our rectal catheter, our urethral catheter. And, the bladder's pretty low here. So we just see a little bit of activity of the EMG, which is the sphincter. As the bladder gets more and more full here, we're seeing more activity, and that's the guarding reflex. Now here, the person is, you can see it down here, is going to try to, so you're getting some spasms or within the bladder, and you're going to get some more activity. And then here, the detrusor is contracting. So here's urination. When you see the urine coming out down here, so we know that's urination. We see a contraction of the detrusor here. We see pretty low abdominal contraction here. So here during urination, we are still having all this EMG activity. So this should be silent. It should look as flat as it does over here. This should be all silent through here. So we have a contraction of the detrusor against an active sphincter, and that's detrusor sphincter dyssynergia.
You mentioned that it could be DSD or a pelvic floor, like the person is not relaxing his pelvic floor, but how do you make the difference in?
So yeah, it's just really honestly based on if they have a known neurologic condition. So if you have a patient who does not have, known multiple sclerosis or doesn't have a spinal cord injury. So you'll see this sometimes in young girls, right? They're kind of like a Hinman's bladder. They can't relax their sphincter. So sometimes you'll see that. Sometimes you'll see it in young women who maybe, at least I see it sometimes in my practice, young women who have really overdone their Kegel exercises, honestly,
Right.
and they cannot relax. I don't know how much you guys see or deal with interstitial cystitis, pelvic floor pain, chronic pain, where both in men and women, really is not just obviously a problem of inflammation of the bladder. It's really a whole pelvic condition. And one of the parts of that can be real hyperactivity or hypertone of the pelvic floor. And that's where, physical therapy comes into play. And more commonly in women than in men, you'll see they cannot relax their pelvic floor. So it's not a neurologic condition causing their sphincter to not relax. It's usually more of a learned problem.
But just to make sure, it will actually look the same.
It can.
All right.
Yeah. I would say it probably wouldn't look as bad as this, but a lot of times what you'll see, and I apologize, I don't have a picture of it, is at the beginning of voiding. So right here, at the beginning, you'll see a lot of activity and then it will quiet down. So maybe the person is having trouble relaxing at the beginning.
Okay. All right.
And so then again, so this is kind of more maybe what you'll see is here the bladder is filling. You're getting, you see a little blip on the abdominal here, a little blip on the urethral catheter here, right? So maybe the person coughed or moved. Their sphincter is trying to keep them from leaking appropriately. Kind of quiets down as they continue to fill, just tonic, normal filling. They're getting more and more full here, so you're seeing more and more from the EMG. And then here is the bladder contracting to push the urine out, and you're getting all this spike from their sphincter. So this is another, it should not be loud like this. And I think at the end I have one that is normal where you're not seeing EMG activity. But that's another idea of detrusor sphincter dyssynergia. So here's a normal this is kind of what my normal urodynamics in a healthy person looks like, right? So kind of what we talked about briefly at the beginning, you ask them to cough just to make sure that you're getting a good signal from both catheters, making sure that your resting pressure in both catheters is pretty low. What they're trying to show here, number 3, is like somebody moved, the person moved or hit the catheter, so you get a little spike. But then your detrusor pressure comes pretty much back down to 0. Bladder's being filled throughout here. They ask the person to cough, right? So you see a spike both in the abdominal and in the urethral catheter, and really no activity in the detrusor muscle. And then they continue to fill. Here you have a wider spike, and this is a Valsalva, right? So you're asking the person to really push down to try to recreate leakage. And then it quiets down again. Another episode where you ask them to cough or to Valsalva to try to get the person to leak. And then here is the detrusor, here is the pressure within the bladder generated to urinate. Here's the detrusor contracting to get the person to urinate. And here's the flow coming out. I don't know. Oh, this one doesn't have an EMG on it, but I think I can go back to the beginning and show you an EMG. But if we had an EMG on this, we'd expect to see some activity, the activity increasing when the person coughs, coming back down pretty quiet. increasing again when we ask them to Valsalva, and then basically low to no activity as they urinate, and then the activity of the EMG picking up again after they've stopped urinating. I think that might be it. Any thoughts or questions or things that weren't clear, or maybe cases that you guys have that are different or odd or concerning, or questions about them?
Well, it would have been nice to have some examples so we can actually kind of practice, because it's a lot of theory, but can we put it all together? I'm not sure. I don't know.
Yeah, I think it's, again, it's doing a lot of them over and over and over again, and seeing a lot of them over and over again once you have a urodynamic machine is really the best way. That, I mean, that's pretty much, I think, how I learned, is reading them over and over and over again. Let's see if I can. I'm going to end this and go back to the beginning. I can just kind of click through this to.
Is there a time when I do ask the person to cough and do the Valsalva? Is there a specific moment?
Yeah, so usually, you know, obviously most people aren't going to leak when their bladder's pretty empty if they have stress incontinence. So we start at about 100, once we have about 150 cc's in the person, we'll stop the filling for a second and ask them to cough and Valsalva. Then start filling them again, and then ask them again at about 250 cc's if they're able to get that high. And then ask them to cough and Valsalva sometimes at capacity when they say they're full. Is the most common time that usually people are going to check. Let's see if I could, trying to see if I can find. So, you know, this is kind of one that's put all together in terms of another example of a full urodynamics all put together. And in this case, I think what you're seeing, you know, here's the EMG here with some activity, showing some contractions and some contractions here, and the EMG increasing again as the bladder's contracting. The person's trying to guard against leaking.
Okay, so I think, as you said, this thing is a very useful stuff that we need to have a better evaluation of the patient. And I think I'm gonna work with our US partners to see if we can have a machine so we can keep learning how to use it and do use this resource for our patients, because we do a lot of TURP and usual structure reconstruction, but I think having this thing could be very useful. And for the woman also who has who have the stress incontinence and stuff like that. So we perform sling also. I think it's very useful. But as I told you, we don't have a lot of experience in this field. And I think for me, I'm not talking for the others. For me, this is the third lectures I have on this, and I used to read articles and stuff on the textbook. But according to what you said and what I understood, it's very important and useful, and I think we should have this thing in.
I think one of the nice things about urodynamics is, unlike some other fields of urology, you know, there's not a ton that's changing, right? I mean, we're still, you know, an uninhibited contraction of the detrusor muscle is an uninhibited contraction, hasn't changed. Neurologic conditions and how they affect the bladder are still the same, you know. So having the information from other lectures and today and other articles, and then when you have a machine, it's not like you need to have the newest and greatest machine. You don't have to have the newest article about it, because the tracing is still the same. And it has been the same for many years. You know, it's not prostate cancer, you know, in terms of new data out and new treatments, right? And it pretty much has been the same for many years. We're still using Dr. McGuire's, storage pressure of 40 centimeters of water with risk to the upper tract. So I think from that standpoint, with the information that you already have and the resources that you already have, when you are able to start doing it, you'll have things to look back on that you don't have to have the newest and greatest up-to-date study, right? Because it hasn't really changed all that much. I think the important ones, obviously you can use it for women who are going to have a stress incontinence procedure, but probably you're already doing stress incontinence procedures and probably doing them very well and don't have urodynamic data ahead of time. It's helpful maybe in the woman who already had a stress incontinence procedure and is now having issues, or has had several stress incontinence procedures, 20 years ago and 15 years ago, and now is still having leakage or new leakage. And, maybe studying that woman before you do a third stress incontinence procedure on her, 20 years later. I think it's also, when you are able to start doing it, it's really important in your patients with spinal cord injuries, I think. Spinal cord injuries, multiple sclerosis, really trying to understand, is there a risk to the upper tracts? Because obviously knowing if a woman has stress incontinence is important, but knowing if a person with a neurologic condition, if their bladder is putting their kidneys at risk, is extremely important.
Okay. So I remember one time I was talking to reconstructive guys, and they asked me, how do you do if you don't have urodynamics? How do you have any prediction if the patient is going to pee or if he has a bladder failure and stuff like that? And I couldn't answer. I told them what we do a lot of counseling, telling the patient that we're going to do the TURP or something like that. But if he cannot urinate after that, he might have this kind of problem. But we couldn't have this thing prior to the surgery to kind of prediction what he's going to have after the surgery, if he's going to pee or something else.
Yeah, I think there's some information that you can get without fancy, machines like this, including, obviously you can measure how much the person went, and you can measure their residual either by cathing them or if you have a bladder scanner.
Okay.
One of my old partners who is now retired, he'd say, stand there and watch them go, right? And if you have a gentleman who it's barely, it's coming out pretty weak stream, and, he went 50 milliliters and his post void is, 150, then, he probably has low flow and, he probably has bladder outlet obstruction, right? He has high detrusor contraction and low flow. A lot of, usually probably the first step in terms of urodynamics would be having just a Uroflow machine.
Yeah.
Which is obviously pretty cheap, and you can get a lot of information from that. Let me go back. I'll just do it this way. So,
sorry, you can go.
Oh, the Uroflow machine is going to give you a ton of information, right? You'll at least get a max flow, how fast they're going, how long it's taking them, and how much they went and what their residual is. So that's going to give you helpful information for outlet obstruction in your men with BPH. Is it going to help you so much with stress incontinence? No, but it could help you with a woman who's had stress incontinence surgery and is now having issues afterwards, right? If she has a low flow, a slow Qmax, and a large post-void residual on a Uroflow, and she has a pretty flat curve, that could tell you she might be obstructed from her sling. So you don't have to have all the fancy, multiple channel urodynamics with an EMG and all kinds of things like that. I think there's a lot of information in the same way you can get either from a simple Uroflow machine or from observing the person to some degree.
Yes, sometimes we use our ears also. When you're listening, the sound of the thing, you can imagine if it's good or you understand.
Right.
So
Yeah.
this is what we do. We do what we have. We do what we have.
That's our technique.
Oh,
Yes.
I think a lot of people would say that is, you know, very helpful. And like I said, I have a partner I used to work with here who is since retired and probably close to 80, and he swore by standing in the room with the man as he urinated. I don't think a lot of people want to do that, but he swore that he got a ton of information regarding bladder outlet obstruction for that. So
Yeah.
yeah, you know, and obviously, like everything in medicine, there's a ton you'll get from the history, right? If the person's telling you that it's barely coming out, you know, a lot of times you just got to listen to your patient, right? They usually know.
Yeah.
Exactly.
All right.
So.
Well, it was very nice to speak with you.
Thank you. Thanks again. It was a nice lecture.
Thank you
Oh
very
yes,
much.
it was great, and I would like to thank you, and I would like to have any other lectures if you have something. Just let us know.
Okay.
And we were supposed to have more people today, but I don't know what happened because I
know.
invited
The time, because it was supposed to be at 5.
Yeah, maybe they are confused with the time. I don't know, because one of them told me it was at 8, but I told him it was at 7. So he's going to be late. But I think the next time we will have more participants to attend this thing. I think it's very important and interesting. So we need to keep going with this momentum.
And I think Katie, you'll have it available, right?
Yeah.
Yeah, I can send it right after.
Right. And I don't know if the slide presentation will be available. And if you need Katie, I can always send you the actual, file.
That would be nice.
I think we're gonna need it. Maybe we can use it to do like
with your residents or something. Yeah. And even just to look back at the stuff. Yeah, I'm happy, Katie. I can send you the file.
Okay, thank you.
Of course.
Okay.
All right. Well, you all take care.
Yeah, and thank you for presenting, Dr. Gibbons.
My pleasure.
And thanks for organizing, Dr. Dreux.
Okay. Thank you. Thank you so much.
All right. You guys have a great day. Happy holidays.
Happy holidays.
Okay. Have a good night. Thank you.
Good night.
Bye.